So thanks to Shield for this wonderful opportunity again to let me speak on this very common but very important topic, that is dysmenorrhea, so that we can find what are the recent advancements and what better solution we can give to our patients so that we can relieve. So I'm sharing the slides now. Please let me know if it's okay or not.
Monica, please mute
Can
yourself.
others mute, please?
Monica, please mute yourself. Yes, ma'am. You can continue.
Yeah. So is the first slide visible?
Yes, ma'am.
Okay, 1 second. Okay, so here we are. What is dysmenorrhea? As we know that menses are a thing which are usually associated with pain, and so people are not very happy when they're about to get their menses. And women, in whatever age group they are, it is definitely associated with some kind of discomfort and agony and pain. So the clinical terminology that we use is definitely dysmenorrhea. It is painful menstruation. It is a Greek name. Dys means painful, meno means monthly, ro means flow. So it's a monthly painful flow, as you can say in a colloquial or a local term. Painful uterine cramps occur a few days during or even after menstruation in certain cases. That is triple dysmenorrhea, as we see in endometriosis. So the duration of the pain, the kind of the pain, the site of the pain, all are related and all signify and tell us towards certain diagnosis which can tell us the cause of the dysmenorrhea, whether any pathological cause or it's a functional cause. So we'll go about it as we are going to elaborate on it. But usually it subsides at the end of the menstruation. Dysmenorrhea is a common condition and refers to painful menses or menstruation with severe cramping effect to the lower part of the abdomen. It leads to the disruption of day-to-day activities. Why are we concerned about dysmenorrhea? Because it definitely affects the day-to-day activities, absence from school, colleges, and educational institution. There's a limitation on the social, academic, and other psychosocial life of the woman. So it is definitely important that we treat this thing and we preserve the quality of life of a woman, no matter in what age group she is. Dysmenorrhea and its effects on school or college absenteeism, as you can see, or the activities among the adolescents, as it's very, very important, because the more we are experienced with this thing, the more we can go ahead with, tolerance and other things. But when it comes to adolescent who are very new to menstruation or very new to menses, it's very, very difficult for them to go about this thing. So the prevalence of dysmenorrhea and school absenteeism was 73% and 13.1%. The school activities were affected. Am I audible? Hello?
Yes, madam. Yes, madam. You are audible.
Yeah, because I just got the power off, so my Wi-Fi goes for a few seconds. So that's why I wanted to make sure. So coming to the class concentration, the participation in the class activities, educational activities, and other social activities. So we can see it is quite a big amount. The dysmenorrhea and the absentees in the school or colleges. So it definitely needs help. What is the prevalence in India? Coming to the geographical sector and the genetic predisposition to various diseases that we have. So how does it affect our Indian women, and what is the prevalence in our country? In India, dysmenorrhea affects up to 90% of the women of childbearing age to varying degrees. So it is such a huge amount because, as we have seen in India, there are many, many diseases, many, many pathological conditions also, which are much more than the Caucasian world and other sectors of the African population. So in India, it affects up to 90%. So we can understand the gravity of the situation and why dysmenorrhea is so important for us. Coming to the various types of dysmenorrhea, as we all know, we have been going through it since quite the beginning of all the doctors starting from the MBBS times. We know this is a very basic classification. There is a primary dysmenorrhea and a secondary dysmenorrhea. The typical age range for primary dysmenorrhea is definitely lower. that is 17 to 22 years. And secondary dysmenorrhea is more common in the older women. So we can see this classification definitely is having an effect on the age distribution. So more often in the adolescent and the reproductive age group, we find the primary type, and in the subsequent years, in the older years, we find the secondary dysmenorrhea, which is less functional in nature. So primary dysmenorrhea, it is defined as painful menstruation in the absence of any pelvic pathology, usually seen in the nulliparous young girls. Here, pain and bleeding are usually associated together. Pain is cramping in nature, colicky, and associated in the midline, and lasts for 12 to 72 hours, or maybe more than that, or maybe sometimes less than that, and some cycles may not be painful too. So it starts within 6 to 12 months after menarche. Some of them usually experience, like post menarche, they experience quite a lot of heavy bleeding, also associated with dysmenorrhea or puberty menorrhagia, as we term it. So the initial few years can be little difficult for the girl in terms of the pain, regularity, and the flow. Coming to other aspects of this one, it is common in nulliparous females, as we have already told, and improves after childbirth. So it shows the functional nature of it. It shows, again, in primary dysmenorrhea, we have several other types which we are going to go ahead. We have our congestive type, the spasmodic type, the membranous type. So we have different types of it also in the primary sector. So the congestive dysmenorrhea specifically, it goes away much more. The congestion goes away much more with intercourses and childbirths, subsequent childbirths. So the positive family history is also very, very important, as we have seen that there is a genetic predisposition and the behavior of the HPO axis and other factors in a woman, the age of the menarche, the age of menopause, the types of other things, and even dysmenorrhea. It definitely has a family significance of the family history and predisposition to the genes. So these are the common symptoms of dysmenorrhea that we all know: lower abdominal cramps, headaches, weakness or fainting. We feel very low and very drained out. There can be vomiting, lower back pain. Besides these, there are many other symptoms, the urgency to pass stools again and again, but not having them. Other factors like, severe cramps in the legs and the lower limbs, and more bloating sensation, gastritis. There are many other GI symptoms associated. So this is not just this much. So it is a wide range of symptoms that we can see. We also find water retention in the body, tightness of the skin, mood swings, irritability. There are so many things associated with it, not just these many. So what is the pathophysiology? Why do we have this primary dysmenorrhea or this functional type of a thing? So the pain of the primary dysmenorrhea is caused by excessive estradiol and prostaglandin, as we know, and production within the secretory endometrial cells. So when there is excessive production of these two things inside this endometrium, we witness primary dysmenorrhea. This prostaglandin release in turn causes uterine contractions, uterine muscle ischemia, and increased peripheral nerve sensitivity. So the release of the prostaglandins, as we know, there is a pathway in which we see it leads to the pain pathway and other things also. So there are contractions, there is ischemia and peripheral nerve sensitivity. Elevated prostaglandin levels, much more in dysmenorrheic women, have higher levels of uterine activity during menstruation compared to asymptomatic women. So various studies and research has shown the levels are highly increased, the prostaglandin levels in dysmenorrheic women as compared to women who do not have dysmenorrhea, and thus there are higher levels of uterine activity and the sequelae that we have already mentioned. Menstrual bleeding is triggered by progesterone withdrawal following the demise of the corpus luteum. This is the basic pathophysiology that happens every month in the menstrual cycle. As we know, as the corpus luteum, there is a demise of it, and that does not lead to a pregnancy. There is a withdrawal of the progesterone, and thus we get the bleeding. And if it goes into the corpus luteum of pregnancy, we do not have the progesterone withdrawal, and thus we do not have the menstrual bleeding, and leading to amenorrhea. Or any other condition having amenorrhea, having the same physiology behind it. As progesterone levels drop prior to menstruation, prostaglandin levels increase together with stimulation of the type C pain fibers and play a big role in pain, inflammation, and other physiological processes, regulating the body temperature in sleep also. As I said, there's a generalized feeling, there is weakness, there is a change in the body temperature, there is sleeplessness, so many things are associated. So it is all associated, and we can see the role of the type C pain fibers here, leading to the inflammatory process that is triggered. Now we can see this. This is the pathway, as we have already seen here, the progesterone, the corpus luteum regression leading to progesterone withdrawal, leading to menstrual flow, release of the prostaglandins and the endoperoxides and the metabolites associated with it, leading to increased myometrial contractions with or without this rhythmia, reduced blood flow ischemia, and thus leading to increased uterine activity, increased uterine ischemia, sensitization of the peripheral nerve terminals to the prostaglandins and endoperoxides and the metabolites. Coming to the risk factors, what are the various risk factors in which we can find the primary dysmenorrhea more, so that when we are going through our patients, we need to segregate them accordingly. Low body mass index, early menarche, prolonged menstrual flow for 7 days or longer, pelvic infections, any kind of it, genetic or family history, premenstrual somatic complaints, history of sexual assault. So these are the few risk factors which we have to keep in our mind, in which we can have primary dysmenorrhea heightened than in other cases. And we can also, together in a parallel fashion, treat your infections. We can treat the other somatic complaints like premenstrual syndrome and other things, and we can definitely supplement them with, nowadays we are having our evening primrosal and vitamin E and other things for the premenstrual syndromes, regular exercise and others to release so many things and regulate the HPO axis. So many things can be incorporated in our treatment when we witness such things, and a proper nutritional status when it comes to the BMI and other things. So we can definitely have other factors as adjuvants in our treatment if we know the risk factors and a probable association of these with the primary dysmenorrhea. So as we can see in investigations, what do we found? We definitely find these things. We have to exclude pelvic infections or pelvic inflammatory disease. So we need to rule out various infections and an increase in the C-reactive protein and others. High vaginal swab and endocervical swabs to exclude infections such as chlamydia and NSAIDs. These are the two very notorious organisms responsible for PID. C125 raised in endometriosis, we need to rule out that cause, because endometriosis is one of the biggest pathological conditions associated with dysmenorrhea. As I said, triple dysmenorrhea being a very significant finding of endometriosis. Pelvic ultrasound to exclude other uterine anomalies, like we have a septum or other Mullerian defects or other things, or a hematometra or a hematocolpus, or other cryptomenorrhea and other things. So many other factors could be associated to the pain associated with it, or collection of the blood, or non-passage of the blood, as in case of Mullerian anomalies. Tubo-ovarian abscess, again leading to endometriosis or any other cause of tubo-ovarian abscess, whether tuberculosis or PID or other things. Endometrioma. Hysteroscopy to diagnose endometrial polyps and submucous fibroids. That can also be another cause, this the type of fibroids specifically being submucous or a polypoidal growth inside. These can also be associated with irregular menstruation and spotting and heavy bleeding and dysmenorrhea. Laparoscopy, again, to diagnose minimal endometriosis, pelvic adhesions, and early PID, because that is a gold standard for diagnosis, which may not be detectable when it comes to ultrasound and other things. So laparoscopy would give us a better, clear, magnified, and a true picture of the problem. Coming to the management of primary dysmenorrhea, the medical management is divided into non-hormonal and the hormonal kinds. Non-hormonal, as we all know, it's very, very common of using mefenamic acid, 500 milligram, can be given 8 hourly, meftal spas and other things. Naproxen sodium, 275 milligram, 6 hourly. Diclofenac sodium, 75 to 100 milligram daily. These are all for the pain management and in the non-hormonal group. Coming to the hormonal group, which we usually take, that is a combined oral contraceptive pills, very regularly and rampantly written, or a progesterone containing intrauterine system like a Mirena and other things. These can also be used to decrease primary dysmenorrhea when the non-hormonal aspect is not helping. So over-the-counter prostaglandin inhibitors, what do we have? That we can give or try. Aspirin 325 milligrams, as we know, recommended dose is 325 to 650 milligrams 4 hourly. Maximum dose in 24 hours can be 3,900. Ibuprofen 200 milligram, 200 to 400 every 4 to 6 hourly, maximum being 1200 milligram. Naproxen sodium, again 200 to 400 milligram, 8 to 12 hourly, and maximum up to 800 milligrams. So these are a few prostaglandin inhibitors which can be tried. And coming to this thing, maximum dosages, as we have already mentioned, naproxen, mefenamic acid already written, 500 milligram 8 hourly can be given, or maximum up to 1250 milligram. Ibuprofen already discussed, naproxen sodium. So these are the few things that are handy, and we do prescribe quite often. So what are the side effects of the NSAIDs? And taking them regularly every cycle and other things can definitely lead to various issues. So we have to be very, very particular. For women, we just give a prescription for a month, but I think women and other people, they just take it over the counter and keep on taking for months, and they come up with so many serious side effects after taking rampantly for months, like gastric irritation, nausea, GIT, ulceration, very, very problematic condition due to prolonged use, nephrotoxicity, headaches, blurred vision, usually due to the phenomids by mefenamic acid, and dizziness, as we can have it from it, bronchospasms in the asthmatic patients, and any hypersensitivity reaction. So these are the few things we have to be very particular when we are giving them, and whether they're using it over the counter over a long period of time. We need to be very particular and take our history and warn them and make them cautious about these side effects. Oral contraceptives should be considered for treatment of dysmenorrhea in women who desire contraception in addition to the pain control. So it can be an added effect also to regularize cycles, to desire contraception, and also for dysmenorrhea. So it can be for various things. So they can be a boon in certain conditions. Combined oral contraceptives yield the best results, with progestin-only contraceptives being less effective. So combined definitely has a better role than the progestin-only contraceptives. Depo-provera may be used to decrease the prostaglandin level. So we can also try that. The oral contraceptive mechanism of action, it inhibits the ovulation, leading to decrease of the prostaglandins, and eventually we have a decrease in the endometrial thickness, decrease the release of estradiol and other things from these endometrial cells. So consequently, so the pathophysiology is reversed. If the measures fail, which is rarely happening, we go for cervical dilatation. If at all we have any stenosis or a collection or anything, we can also try pre-sacral neurectomy if all other measures fail. It is a surgical removal of the pre-sacral plexus, the group of nerves that conducts the pain signal from the uterus to the brain. It is indicated for the treatment of central pelvic pain, including severe dysmenorrhea. So it has been tried in many cases when there is severe pain and there is no relief from other things. So we can think of removing surgically the pre-sacral plexus. What else may be helpful to improve dysmenorrhea? As I said, we can try a holistic approach towards it, to continue the normal activities, to have a gentle abdominal massage, regular exercise, very, very important, avoiding stress, avoiding lack of sleep. So these are a few small things, but together, when they come together, or a lifestyle change, as we can say, we can bring about it. Definitely, takes away or decreases the symptoms by quite a huge percentage. What are the remedies of dysmenorrhea? If we go for the more non-medicinal pathway, we have ginger, we have yoga, mint, angelica sinensis, as we can see here, beet, cinnamon, balanced diet, aloe vera. I think these are the things which are good for any kind of disease in this world. So no harm in having the good things which nature has provided us, or the good practices like yoga and other things which our Indian tradition has, or having a balanced diet and regular exercise. This can help you for everything and restoring every system and the wellness in you, not just dysmenorrhea. So the investigations, as we have already mentioned about it, I need not repeat them. We need to rule out other causes of it. We need to check the basic blood levels, and we sometimes can go for the marker like CA125 for endometriosis, or rule out the infections, take a vaginal swab or a pap smear, or any other fluid during laparoscopy for testing for tuberculosis and other things, to rule out other causes of it, or a hysteroscopy to find out polyps and other growths and fibroids inside, or a simple saline infusion sonography, or a normal pelvic ultrasound to rule out anomalies and other things. So these are the various basic investigations in the OPD in the lab that we can carry out to rule out other causes, so that we can pinpoint on primary dysmenorrhea. Coming to secondary dysmenorrhea, it is much easier, because to diagnose or to, a specific targeted treatment for this thing than primary dysmenorrhea, because it's a very, broad spectrum kind of a thing, and it becomes difficult for us to know the reason. But in case of secondary dysmenorrhea, it is usually due to an underlying disease of the pelvic organ. As we can see, the various positions of the fibroids here. Not just fibroids, there are many conditions, whether adenomyosis, endometriosis, and any polyp, or any Mullerian defects, as already mentioned, septums and other things, or your cervical stenosis, or septum down there, transvaginal septum, or any such kind of a thing can lead to secondary dysmenorrhea. So what are the various causes that that has been listed here? Gynecologic causes, number one being endometriosis, followed by congenital anatomic abnormalities, as I said, Mullerian defects, Mullerian fusion defects, sexually transmitted infections, another very, very important thing that we need to rule out, pelvic inflammatory disease, adenomyosis, uterine leiomyoma, or fibroids in our general term, as we said, no matter what the location or the size of the fibroid is, cervical stenosis. Coming to the non-gynecological aspect of it, why can we have secondary dysmenorrhea? High tone pelvic floor dysfunction. That is another very important thing. Irritable bowel syndrome, bladder pain syndrome, pelvic adhesions, inflammatory bowel disease. So these are the few non-gynecologic reasons which we do not keep in our mind, but it is very, very important to have them in the mind when we are not able to, target get a pinpoint a diagnosis or give a targeted treatment. We have to think about IBS or adhesions or inflammatory bowel disease or some form of dysfunction in the pelvic floor. Here, as we can see, a typical appearance of the endometriotic spots, which we find in the laparoscopy, very, very, the biggest cause of secondary dysmenorrhea being endometriosis, and the biggest headache for a gynecologist. Very difficult to make the adolescent age group and the reproductive age group of women understand why it happens and why you're undergoing through so much agony and pain. So we can see the endometriotic spots, as we know, any kind of blood that is there, changes its color slowly from red and all that. It goes up to your brown blackish spots, which are, it can be gunpowder spots initially, then go up to these kind of things. So these are the endometriotic spots in the pelvis that we can see. We can find chocolate cysts in the ovary, or any other deposits, in the POD, in the uterosacral, thickening of the uterosacral ligaments. Very, very characteristics of the characteristic features of endometriosis. So here, as we can see, the STD causing bacteria may enter the vagina with the semen. When it comes to sexually transmitted infections, the bacteria may pass through the cervix and enter the uterus. The bacteria enters the fallopian tubes and ovaries, which can become infected again. So the infection can leave the fallopian tubes and spread to other parts of the body. So this is the route of transmission of the infection, or any such kind of ascending infection, as you can say. And here we can see the gold standard again for diagnosis in PID, like endometriosis, is laparoscopy. We can find the edematous tubes or hydrosalpinx, as you can see here. We can find peritubal adhesions or a purulent exudate emanating from the femoral end, or we can find fluid collection in the pouch of Douglas. We usually take it for testing and to rule out any other tubercles or white projections or spots on the pelvic organs. We usually take it for biopsy to rule out tuberculosis and other things. Any paratubal cyst, hydrosalpinx, tubo-ovarian masses, ruling out tuberculosis, and chlamydia and Neisseria. So there's a typical appearance of all of it, especially in chlamydia. You find a lot of adhesions inside, pelvic adhesions with stringy kind of adhesions as a very, very characteristic feature of chlamydia. Coming to the diagnosis, how are we going to diagnose them? History, of course, as I said, till now we have been talking about pathophysiology, risk factors and all that all comes from history. Family history also very, very important. So the onset of symptoms, several years after menarche, just after menarche, when after menarche, recurrent pelvic infections, fever and vaginal discharge, any form of IUCD, intrauterine contraceptive device inside, recent pelvic surgeries to rule out adhesions, heavy periods which may give us a direction towards adenomyosis or a polyp or a fibroid, infertility and dyspareunia, which is mostly with endometriosis. We know dyspareunia is a very, very common complaint. Painful sexual intercourse or painful defecation, constipation, irritability of the bowel, all can be there in endometriosis, and infertility, of course, very, very important. Tuberculosis also with infertility, and PID also with infertility. So a physical examination may help in the diagnosis by finding abnormalities that point to a pelvic disease. Investigations, laboratory and other things, what we can do. Sorry. A complete blood count, anemia related to chronic menorrhagia or infection, a cervical or vaginal swab for cultures to rule out any infection of PID, transvaginal ultrasound to rule out pelvic masses, uterine fibroids and polyps, pelvic abscesses or adenomyosis, a laparoscopy, which is a gold standard again for diagnosis of anything. It can be diagnostic as well as therapeutic, particularly in the management of endometriosis and where pain is of uncertain origin. If the chocolate cyst and others can be approached or certain endometriotic tissue can be excised without damaging other things, we can also be using laparoscopy as a therapeutic tool as along with diagnosis. Hysteroscopy defines the intrauterine pathology and provides an endometrial tissue sample for histology. Coming here, again, we can see a beautiful schematic diagram. We have already discussed most of the things here. Medical history, history of primary dysmenorrhea, no previous diagnosis of pelvic pathology, menstruation associated cramping in lower abdomen, pain, plus pain, which is like the onset is 6 to 24 months after menarche, as a predictable temporal pattern just before and or during menstruation, typically lasts for 8 to 72 hours, may radiate to the back and the thighs, may be accompanied by systemic symptoms like diarrhea and vomiting. So this is like a broad picture of the primary dysmenorrhea. Physical examination, no pelvic pathology, then primary dysmenorrhea, of course, these three things with no pelvic pathology, primary dysmenorrhea. If we find a pelvic pathology, we have secondary dysmenorrhea, which also again has no history of primary dysmenorrhea, like pain onset more than 2 years after menarche. So there is a difference. It is within 2 years, that is more than 2 years. Irregular menstrual cycles, pain during non-menstruation phases also may have other symptoms like menorrhagia and intermenstrual bleeding. So this is how we differentiate between primary and secondary dysmenorrhea. Coming to other things, as we have already discussed, but just going through it again, the onset, usually 6 to 12 months after menarche. This is more than 2 years. Time present during ovulatory cycles and menses only. So when you have primary dysmenorrhea, it is also a good thing that yes, the woman is ovulating, because nowadays we find anovulation so much with lifestyle change and polycystic ovarian diseases being rampant. We usually find anovulatory cycles. So good that ovulatory cycles are there. And secondary dysmenorrhea may not necessarily be associated with menses. 15 to 25 years of age, broadly, we can call it to primary, and in secondary, we have after usually 25 years of age, 30 to 30 to 45. Duration 8 to 72 hours, basically. Secondary dysmenorrhea prior to onset of menses and throughout the menstrual cycle, and otherwise also. Symptoms, what are the differences that we can see here? Back and thigh pain, headache, diarrhea, nausea, vomiting in case of primary. In secondary, other gynecological symptoms like dyspareunia, menorrhagia, infertility, and other things. Pain, lower pelvic or abdominal pain, usually associated with onset of menstrual flow without pathological disease, lasting, again, we have told, may complain of change in time of pain onset during menstrual cycle. It is associated with underlying pathology, as we have already discussed, need not say it. Primary dysmenorrhea, it gradually improves over the time with sexual intercourse and having a childbirth. But secondary dysmenorrhea, it becomes worse over time. Sexual activity improves it. Postpartum, it gets improved. Secondary dysmenorrhea, no change in relation to sexual activity or postpartum. Findings of internal examination, no abnormal findings. Of course, we find some pelvic pathology or an abnormality in case of secondary dysmenorrhea. So broadly, this is how we can differentiate in our OPD and IPD. Dysmenorrhea should, however, not be confused with premenstrual syndrome. Very, very important, which represents with similar symptoms. Premenstrual syndrome, as I said, there'll be irritability, mood swings, water retention, uneasiness, and so many breast pain, mastalgia, so many things, factors associated. But dysmenorrhea has to be, differentiated from it. PMS or premenstrual symptoms resolve shortly after menstrual flow, have begun, unlike dysmenorrhea, which continues up to 72 hours. PMS, a group of physical, emotional, and behavioral symptoms that occur in the second half of the luteal phase of the menstrual cycle, just before the onset of the menses. It often interferes with the work and day-to-day activities. Here, period of symptoms entirely free, starting with menstruation. Once your menses set in, PMS and its symptoms usually fade away, but not in the case of primary dysmenorrhea, in which it starts maybe with the menses and does stay at least for 2 to 3 days. The first 2 to 3 days. Symptoms in PMS: bloated feeling, weight gain, edema, breast pain, tenderness, hot flushes, headache, nausea, pelvic pain, change in the bowel habits, joint or muscular pain. Emotional symptoms like irritability, aggression, tension, anxiety, depression. What causes premenstrual syndrome or PMS? Not many known theories. Various hormonal interactions lead to this. Vitamin B6 deficiency can be associated by various studies and researches, and a psychosocial element is definitely associated with it, which can be taken care of with a different kind of a lifestyle, reduction of stress and anxiety through yoga and physical exercise, and other factors. Ovulation and progesterone production are important in this syndrome, and drugs that inhibit ovulation relieves the PMS symptoms. So very similar to it, but yet there is a difference between primary dysmenorrhea and PMS. Management of premenstrual syndrome or PMS, counseling and reassurance that symptoms are real and it could be treated. Lifestyle change, again, lifestyle change is the first and foremost answer. Exercise, dietary modifications, at least 20 to 30 minutes. It increases the endorphins in the brain, distract the woman from her emotions. Medically, what we can give symptomatically for bloating or water retention, we can definitely give her a few diuretics, antiprostaglandins for the cramping pain, bromocriptine and others for breast tenderness. Ovulation suppression can be done with oral contraceptive pills, danazol, medroxyprogesterone acetate, continuously given for a brief period of time. Or, as I said, evening primrose oil and vitamin E and supplementation with vitamin B6 and other things can definitely improve the symptoms of PMS if they are worse. Coming to the management pathway for dysmenorrhea, we are suspecting dysmenorrhea, no pelvic pathology, suspect primary type, recommend the treatment, non-pharmacological, effective, then continue that, not effective, go to NSAIDs. If effective, again continue and reassess 6 monthly, not just keep on continuing it without cessation of the drugs leading to side effects, as we have mentioned earlier. If NSAID is not effective, we go for hormone contraception. If they turn out to be effective, we continue. Again, we continue, keep on following up every 3 to 6 months. If not effective, again, hormonal contraception. We combine NSAIDs with hormonal contraception or consider other like Depo-Provera, dipomedroxyprogesterone acetate to reduce prostaglandins and others. Again, not effective. We refer to a specialist, go through again, screen, diagnose, try to find out any other suspected secondary dysmenorrhea. So this is the basic, management pathway that we can follow for dysmenorrhea in our clinics. So what is the take home message here? Like we've discussed so much about dysmenorrhea, we find it very, 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 commonly girls coming up to it. But what I have practically, before I end it or I take back anything else, I would like to say that we find it very, very difficult in the adolescent age group just post menarche when they come to us. First of all, they're very, very irritated with their menses happening. So it is our duty, not just leave it to the family members, because family members cannot give that kind of a scientific assurance or reassurance to the patient. So it is our duty to also take care of the mental health of the patient, especially the adolescents, especially the puberty attained girls, and try to reassure them that it is okay, it is real, it can be controlled. Life is not getting over with this kind of a pain. Things are going to improve much, much better with primary dysmenorrhea, with childbirth and other things happening. But till then, because nowadays most of the women are career oriented and others, they may have to go through it for many years. But we need to give them a proper guidance. More so if there is a secondary cause or a secondary dysmenorrhea like endometriosis and polyps and other things, we have to tell them the right age, how to go about the reproductive the life, and when to conceive and when not to delay and what to do. All these kind of specific advices, I think we have to give them. And minor things, just lifestyle change, as I said, when it comes to the younger women in primary dysmenorrhea, we need to encourage them, we need to boost them, we need to tell them the pros and cons and why is it happening, how to control their emotions and keep calm. And again, in secondary dysmenorrhea, we need to pinpoint the diagnosis, go about the treatment, tell them that it's okay and we have to fight it, and not just get defeated by the diseases like endometriosis specifically, because it is a very, very, mentally, emotionally, physically, financially draining kind of a disease, endometriosis. Also, especially if it goes up to infertility, that is even more dreadful. So we need to be with a woman as a clinician and as her first reassurer, or as you can say, like therapist, or take part of her mental aspect of the thing, because the clinical aspect we have discussed a lot and we know what to give. But this is something, the extra added touch, which is our responsibility, because still the patient does not accept her problem, does not have it in her mind that I'm going to fight this disease, I think all the treatments and everything are going to fail, because it's very important for her to have it in her mind that dysmenorrhea is okay. For whatever reason I'm getting it, it is something which is natural and real, and I'm going to fight it every month. It is highly prevalent, as we know. That is why we're discussing it and we're finding solutions to it. The findings suggest family history, and of course to incorporate the family also, to support her, to reassure her, and to be with her in her times of pain and agony. Bleeding duration and presence of clots are also significant factors. Appropriate intervention through change in lifestyle, as we see, even for a polycystic ovarian syndrome or endometriosis or any other hormonal related things, change in lifestyle, because we find more so of these things nowadays because of the change in lifestyle. The barriers to seek medical attention by dysmenoric females need exploration. We have to let her confide in us so that we can reassure her. It is important that health education on puberty and menstruation, as I said, because they're in shock usually. The young females, 10, 11, 12 years girls, when they just attain menarche, having severe pain, rolling down in the houses. So we need to first, it's also the responsibility of their mothers and sisters and all to make them aware at least 1 to 2 years before it, given the family history of early menarche, late menarche, whatever. Counsel them that yes, you're going to have this, you may have this, so that suddenly they're not in shock. because in most of the families, whether educated or uneducated or whatever, it's still a taboo to talk about menstruation and its related effects and stopping the woman from doing activities. All those myths associated with menstruation still exists in most of the family households. So it is our duty to keep on breaking the myths, keep on stopping the social barriers, especially in our Indian society, which do exist, the taboo which exists with menstruation and its problems. So then only we can fight dysmenorrhea, because as such the woman is treated as a left out or segregated during menses in the house. So that cannot be done anymore by the family members, because it is not correct to do so. So we have to first make the family understand the issue and the problem, so that they can be a big support system to the girl. This ignorance might adversely affect the medical attention seeking behavior. So if they do not understand that there is a problem, they would not even come to us to seek medical attention. In case of these dysmenoric females, especially the adolescent age group, as I'm telling you again and again, because once the reproductive age group comes, or an infertility sets in, or the irregular cycles, they do come and seek medical attention. But before that, it's just tolerating and keeping it inside and having a very bad quality of life. So I think we have touched all the aspects of dysmenorrhea, tried to segregate both the types. As I said, one more thing that I said, there are different kinds of dysmenorrhea, whether that's a spasmodic, congestive, or membranous, going into the details. But no matter what the type of it is, this is the basic approach that we're going to go, whether non-hormonal or hormonal treatment. I think this should help us out to treat dysmenorrhea and make our women happier and have a good quality of life. Thank you so much.